you so much, Dr. McKernan, for being here. Dr. McKernan came highly recommended to me by my father-in-law from the Beaumont Club, who's actually the reason I got into Rotary. So I think he has pretty good judgment. With that, to introduce Dr. McKernan specifically, he's the Associate Dean for Clinical Affairs at Sam Houston State University, College of Osteopathic Medicine. I hope I got all of that right. But in emailing back and forth and speaking with Dr. McKernan before this, was really excited to hear what he's doing and kind of his thoughts around how he wants to serve maybe smaller communities throughout the nation. With that, and without further ado, Dr. McKernan, I'll let you take it from here.
All right. Okay, so basically, I've been with Sam Houston State University since January, but I've lived in this area since 2003 when I joined the Family Medicine Residency in Conroe, and I ran that for several years. And in that residency, we created a community health center, which served the underserved for our residency clinic. Prior to that, I actually taught at a rural medical school in Missouri. You're all talking about cold. You don't know cold until you live in northern Missouri for a while. And before that, I lived in California, and I was a doc in a rural town where I participated on the hospital cattle penning team because we didn't have any other thing to do in that town. Anyway, so basically, Sam Houston State University, as you may or may not know, has always been a workforce-based university. So they create programs because they're told they're needed, not because they just want to create programs. So they got into health education with an athletic training program, a nursing program, a food and nutrition program. And the community started saying, well, you know, we need doctors. We need doctors who will practice primary care in the communities where they need doctors. So Sam Houston State University started that process. And the mission became exactly that, to emphasize primary care, rural practice, underserved communities, and create physicians who wanted to do that. Excuse me, with the model being that we want to recruit people from communities where doctors are needed, and hopefully they will go back to their community when they're done, which is kind of a unique way to do it. So the idea for this started in 2013. I was in the community, so I was one of the people they came to talk to about starting a medical school. And, you know, we all hear sometimes that you don't need more medical students, you need more residencies in the state. But without medical students, you don't get the same bang for your buck on the residencies because people come into the state and then they leave after they do their residency here to where they're from. The Texas State University system had to say, okay, Sam Houston State can consider starting this. And they did that in 2016 after a lot of research. And then the dean was hired in 2016, November. Dr. Henley was someone I knew from previous in education. And he called me and to see if I wanted to join him in this effort. And I did in January 2017. So we started the process of starting a school from scratch. We had a piece of paper and a couple of small desks. And we actually started working with the accrediting body to get that done. After we did that, we had to create a curriculum, do a whole bunch of preliminary work, and the Board of Regents for the Texas State University system approved us actually moving forward with the coordinating board, which is the entity in Texas that approves state school programs, no matter what they are. And so we went to the Texas Higher Education Coordinating Board in August of 2018. And actually went in 2017, but got approved by 2018. And then in Texas legislature approved us in 2019 as a state medical school. Governor signed that bill. And then we started the process of starting to collect students. Again, we got pre-accreditation from our accrediting body, which is what any medical school gets until they have their final class before graduation or at graduation. For a state medical school, we had to go through the Texas Medical and Dental School Application Service. And they close applications in October, which is very early compared to other schools. So we had about a month to do our first recruitment. The good news was that we got a very good class. We got people from the regions we wanted, where doctors are needed, which quite frankly are all over the state of Texas. And our first class started their orientation on August 3rd, and we started our first day of instruction on August 10th. And now we're interviewing for the next class. So the assembly line continues. We start them and we get the next group coming in. So interestingly enough, this is the first time since 2018 that medical schools have had to deal with a pandemic. And we've been told that's the first time medical schools have been started during a pandemic. And so it was quite a challenge. We completed the construction of our building in February of this year. And then we were out of the building again in the middle of March because of the pandemic. If you recall, at that time, a lot of things were closing down because we didn't know how fast this was going to spread. And then we continued to get furnishings and equipment brought to the building with no one here. So ended up with a loading dock and a lobby full of boxes and equipment. We had a partial return in June. I, as an administrator, actually came back in May. In June, we started having people come back in groups so that it wasn't full in the building. And then we had full return with the safety measure we decided we needed in July. And understand that was when everybody came back and we were starting students in August. So it was a pretty hectic month. So we had to institute curriculum changes for student safety, and we had a plan to live by Zoom. So I'm sitting here with 2 computer screens, a camera, and a special Zoom light so that I can live my life mostly in Zoom. So we did a hybrid delivery plan, hybrid meaning that sometimes people are in person, sometimes they're not. It's really hard to treat a medical curriculum without in-person time. So the in-person groups that we have are for osteopathic skill sessions, our clinical skills sessions, and our anatomy lab. We broke them into very small groups, and we never had more than 10 people in a learning group. And that increased teaching responsibility for the faculty. And sometimes I hear my own daughters in law school say, why do I have to pay full tuition when everything is remote? And I said, because it's a lot harder for us to make remote and to do it several times than to do it once. So we really initially had no more than 20 students in the building at one time out of our 75 student class. But as we built the building actually with a lot of small rooms, so we decided to allow the students to come in the building in their small groups, and it's a designated group. You have an assigned room, and your study group is the same people all the time. And so we instituted building safety measures, which included mask wearing at all times, social distancing, marks on the floor. We have chairs that have X's on them. You can't sit on them, they're too close. We do temperature checks initially entering the building. Now we do it entering labs, because that's where people are in close contact. We do a lot of surface sanitizing. The university has a program that's put sanitizer down that supposedly lasts a long time. Frequent hand washing and constant reminders and signage. In addition, as a new building, we're able to put in filters, UV filters that kill most viruses. We're not sure that kills coronavirus, but we assume it does. And then recently we added another program where every Monday, everyone has the opportunity to get tested. With the clinical focus, the university decided to put the building for medical education, Conroe, mainly because it's a central location for the student sites. We don't have one big hospital we're going to. We're going around the state, on the east side of the state. And so it was a central location. Additionally, the developers of Grand Central Park donated the land for us to build on when they heard that we wanted to build in Montgomery County. It's a former Camp Strake development site. It says June, that's an error. It's class started in August. We're interviewing for our second class now, and our second class will be 112, up from 75. That's an accreditation process. You don't start with your full approval. And then we have our first site visit with students coming up in January. So our current major affiliations really where our students will start their rotations in 2022 are Oak Bend Medical Center in Richmond and west of there, HCA Conroe and Huntsville Memorial up in this region, Baptist Christian St. Elizabeth Medical Center, Southeast Texas and Beaumont and Port Arthur, and Nacogdoches Medical Center, Nacogdoches Memorial, St. Luke's Memorial, and Woodland Heights in Lufkin. And then we have multiple rural hospitals scattered around the state. As far as Spring Branch area goes, quite frankly, we expected to have hospitals in the area, but with acquisitions and changes in leadership, we actually lost several hospitals that we expected to be in that were in your area. And so we do have medical student applications from that area, actually quite a lot of them. So we're still hoping that something will happen in that area of Houston outside the main downtown area. We'll be able to have some students in rotations out there. Because if we can take a student from an area, we have to train them in a main building in Conroe. But if we can then send them back for rotations where they came from, they're more likely to stay there, even if they do a residency somewhere else. Texas has a unique statistic, and that is that even students who leave the state for residency are more likely to return to Texas to practice at a rate of about 60%. And we're one of the few states that accomplishes that. And so even if our students leave for residency, they're likely to come back, and we would like them to go back to where they're needed. So what are we doing now? Well, we're planning for the students to start their clinical rotation in July of 2022. And we're going to have our first class graduate in 2024. And so that's when they will start residencies. We're still looking to add additional clinical sites, hospitals, clinics, and the like. We're continuing to recruit physician preceptors, physicians who will take students into their offices and into their practice in the hospital to teach them. And then we're still trying to develop residency programs in the service area. And again, we want to put them in places where students come from so that they can do their residency there also. I have a short video that shows you our building. So let me know if you can hear it.
Welcome to the Sam Houston State University College of Osteopathic Medicine. After more than 6 years of researching, analyzing, and planning, Sam Houston's 8th and newest college is now a reality. The 4-story, 108,000 square foot building is housed on 7 acres in Conroe, Texas, and is the first medical school in Montgomery County. Nestled among the pines in Grand Central Park, the impressive glass and steel college was designed to encourage collaboration among the medical students and features open spaces, flexible learning classrooms, and state-of-the-art simulation labs. The standardized patient suite is an interactive learning environment that mimics a doctor's office or clinic and includes 10 simulated patient exam rooms and debriefing room. On the same floor, a simulated hospital allows learners to replicate pediatric and adult scenarios within surgical suites, recovery rooms, nursing station, observing, and debriefing rooms. The interactive teaching theater seats 160 learners and is used for lectures and guest speakers. Each seat comes equipped with a charging station and microphone. 6 oversized screens ensure a clear and unobstructed view in the auditorium-style room. 4 learning communities provide a comfortable environment for students to collaborate with one another, study, or just relax and unwind. In anatomy, students learn how different parts of the body relate to medical conditions. Located on the 4th floor, the high-tech anatomy lab is equipped with dissection tables, examination cameras, and monitors. Osteopathic manipulative medicine is an essential component of our curriculum. In the Osteopathic Clinical Skills Training Room, Students will experience the integration of osteopathic principles and practices. The room accommodates 75 learners and includes 42 adjustable tables designed to allow the performance of osteopathic manipulative medicine. Sam Houston State's history of contributing to the well-being of the state started more than 140 years ago when the university was established to respond to the need for trained teachers. Today, the university has responded to another critical workforce demand: shortages in primary care physicians, and Sam Houston's osteopathic medical education will be key to elevating the quality of life for millions of Texans in rural and underserved areas.
So basically, my background was I was a family doc in a small town. I delivered the babies. I worked in the ICU. We used to joke, my partner and I, that we were the ushers. We ushered people in, we ushered people out. I went into education actually to further the idea that working in a small town, working in a community where people know each other is actually a good thing. And so I ended up in a rural medical school in Texas, or Missouri, and then came down to Texas. And here I am at Sam Houston State trying to do the same. There are so many communities in Texas that need doctors. We're going to be short by thousands in just a few years because we're already short. That's why I got to do this, and that's why I'm at San Joaquin State University in their medical school. I'll take questions if anybody has them.
Dr. McKernan, this is Travis Taylor. I've got a question. Did that video say that there was a shortage of primary care physicians coming out of med school? Did I hear that right?
Well, primary care you do as a residency, but yes, there's a shortage of the big shortages in Texas are primary care, family medicine, general internal medicine, pediatrics, and then also the worst is actually general surgery, and then psychiatry is in that list also. So those are the things that we're most.
I represent a lot of physician groups, and I think the grumbling is it's a poor business case coming out of med school to focus on primary care. Am I saying that right?
You're saying that right, but it's wrong.
Okay.
So I've been a family doc my whole life. It depends on what you do and how you do it. I've had a very successful career, both reputation-wise as well as financially. Remember that a family physician completes residency in 3 years rather than multiple years. So anytime you can start your career earlier, you do okay. Your loans don't increase. Certainly, if you go into medicine for the money, you're not going to be a family doc. But frankly, I went into it to do this because I thought it was important. And because I didn't chase the money, I did very well financially because people recognize that. I grew up as a physician in California in the beginning of managed care. And I did very well. So,
and I'm not suggesting that doctors are greedy or chasing money, but it would be nice not to be in debt until you're 45 years old.
Well, I had high debt and I paid it off in my first 8 years. So
good for you.
I mean, the fact is this: if you become a physician, you make a good salary no matter almost what you do, right? And the fact is that there are people who have student loan debt that take many, many years to pay it off. And some people default because of the careers they're in. A physician of any type can pay off their student loans. And so to me, that's not a major issue. And I always tell medical students, do what you want to do and what you love to do, because there are a lot of people who pick specialties based on income, and they're not happy in those specialties. So I think people need to pick what they love to do because you make pretty good money as a physician, no matter what you do.
Doctor, I wanted to ask you a question. Of course, being a Bearcat, but also growing up in Huntsville, I can appreciate we had a shortage of primary care doctors as I was growing up there. And do you actively recruit in smaller towns and smaller areas with the idea that given the nature of it, that the people that you recruit will then migrate back into those areas?
That is certainly our hope, and there's evidence to say that that's what is likely to occur.
Okay. And I guess these docs then would maybe work multiple small towns in a given area. Is that?
No, they tend to pick a town. The way it works is that for primary care docs, there's a wide array of patients that you can see, especially family medicine. I could see from pregnancy to, late geriatrics. So you can go. So when you're in a town, you can see a lot of people. Unfortunately, there are some towns in Texas that have no doctors. There's some counties in Texas with no doctors.
Yeah.
And so people do have to go far. But the hope is that people can get care close to where they live. So usually they go to the doctor rather than the doctor going to them. Although when I was in practice, I went to 2 small towns with a hospital between those 2 towns.
I'm just curious about the direction that a lot of doctors are going into, more of a concierge program, and to avoid having to deal with insurance companies and whatever. What are you seeing?
Well, I'm torn on that. I understand why they're doing it. Insurance companies limit patients and limit doctors. There's no doubt about it. Some of it is appropriate. Some of it may not be, depending on what they're doing. I do have a concern that concierge practices also exclude a lot of people who need healthcare. And if everybody did that, they wouldn't get it. I think that people should be able to get healthcare because, quite frankly, loss of access to healthcare costs us more because you can always get emergency care, right? And so if you wait until it's expensive emergency care, we're all paying for that somehow. We're either paying for that through our state system that covers people, or we're paying for that through our insurance because of the cost of care overall. I understand why people do it, but I have concerns that if everybody did it, we would have a 2-tiered system, and a lot of people would not be able to get there.
I have a question. I work for a nonprofit. We do heart screenings in schools, and we work in a lot of rural communities for the reasons that you mentioned, right? There aren't clinics, there aren't doctors, there's no medical access in a lot of the places where we work. So if you're a new doctor, or any doctor really, setting up in a rural area, would it necessarily be a private practice, or could you do it through a hospital system?
You can do it through a hospital system. Some of the hospital systems do have physician groups. I did it privately, and certainly that was years ago. But really, there's a higher incidence of private practice in rural communities than there is in more urban communities. The more urban you get, the more likely the physicians are to be employed by someone. And there's also a rumor that you make less money in rural communities, which actually isn't true either. And also the cost of living tends to be less, and the cost of running a practice tends to be less. But so there is a lot of physicians that set up rural practices that are private practices, often going in with somebody, sometimes getting the hospital to help them set up. But the employed model is increasing also in the smaller communities.
I would think a rural community would be a lot more startup costs for a private physician. And I think that seems like a lot of doctors go to work for hospitals because of the startup costs.
Well, but hospitals will help you with startup costs often with a payback. And so you can do that. If you go to a place where they really need doctors, you get busy right away. So those startup costs get covered pretty quickly. When I went to a town, they needed docs. And so, my first month in practice, I had almost a full practice. So I didn't have a long period before I had to start getting income. There is a delay from insurance companies paying you, of course. So you wait 3 months for that.
Yeah.
But when you see that your practice is full, I had actually an income guarantee that I never had to use. So.
And at the risk of monopolizing your time with questions, I have one more. Does your school, or do most medical schools, address training doctors on how to be working for themselves? The accounting and just all of the administrative stuff seems like it can be overwhelming sometimes.
Medical schools, some medical schools, we will try to do that. But the truth is that they don't listen much until they're in residency and getting ready to finish because it's not the forefront of their world at that point. But we want to do that to tell them what's available, what they can do, and what the options are while they're in medical school. So they think about that when they're selecting their residency program.
Yeah, Warner, thanks so much, Dr. McKernan. It's been a great presentation. I personally am not too familiar with the whole field of osteopathic medicine. Could you give us a 2-minute, 3-minute kind of summary of where it came from, its standing now, its growth, everything like that?
And so, well, osteopathic medicine started in the 1800s. It was started by actually a physician who was a surgeon, and he discovered that some things he could do physically would help people get better. We are physicians that do everything that a MD does, with the addition we do manipulation, which is different things. It's not necessarily popping and cracking, it's different things to help people with musculoskeletal pain, will help the function of the body, basically. Right now, as of 2020, DOs and MDs do the same residencies with the same accrediting body through the ACGME. And I did a residency through the ACGME. That was the only DO in my residency. I went there so I could do rural practice. The fact is that I do everything plus manipulation that my colleagues in the MD world do.
I just want to add on to, Mary, I thought you were going to say, do they teach in your school how to be good bedside manner physicians? And I think that that whole program that you've got is to treat the whole person, the mental and the physical.
Well, truthfully, part of your recruitment process is to get the right people who will do the things you want them to do. But our physical medicine course is the beginning of it, is how to deal with people, how to have bedside manner, what patients expect, that kind of thing. And so that's part of the program. And actually, every medical student, whether they're an MD or a DO now, is, well, right now it's stopped because of COVID, but there's a part of the exam that you have to take where they for licensing, they base you on that. So there's a lot of new things. I didn't go to medical school. I had a fake hospital and fake exam rooms and all that thing. When I did, we had to learn in the doctor's office and a regular hospital. But there's been a lot of advances in medical education. That doesn't mean everybody does well when they get out.
You have any thoughts about, we alluded to this earlier, about the distribution of the vaccine?
Well, the real problem with the vaccine is we are limited in the number of doses. And so it's being rationed based on need, and it's looking at the greatest need. So certainly they want to do healthcare workers because healthcare workers are most likely to be exposed. And then the elderly in nursing homes because of the nursing home pandemic that happened. I don't know if you know this, but the worst nursing home outbreaks have been in veterans nursing homes. And the most deaths. And that's partly because veterans homes tend to be mostly very elderly male patients or residents. We don't know how fast it's going to come. They've decided that they're going to do it the same number of doses, they say, by the week, but not in one big shipment, because that has proved to be difficult. Probably we will have about 50% of the people immunized by the middle of the summer. So our masking and stuff will not end in the spring, unfortunately. But that depends on how many people are willing to get immunized. There have been some reports of people getting some pretty bad reactions, but understand that those are few and far between, and those can happen with a new medicine someone takes. It can happen with any injection someone gets. So I hope that's not scaring people away from it. All of the vaccine experts think that this is a new vaccine, but it's based on a technology that has been in existence. So it's not something totally strange and totally new. I will get the vaccine as soon as it's offered to me as a healthcare provider, and I hope it's offered soon.
Well, thank you so much, Doctor, for joining us. I mean, that's an incredible presentation, and as a Bearcat, I'm very proud to have the College of Osteopathic Medicine in our school. So thank you for all you're doing.
Well, I appreciate the opportunity. Thank you all, and have a Merry Christmas.
Thank you very much, Doctor.